My name is Cray Bolger, one of the ultrasound faculty at Ohio State University, Department of Emergency Medicine. Today we will be covering basic cardiac ultrasound. As with any ultrasound exam, we must discuss the indications, the acquisition, the interpretation, and medical decision making. For the purposes of this lecture, we will be discussing physician-performed focused bedside ultrasound. This is different than a comprehensive echocardiogram ordered by a physician and acquired by either a cardiologist or a sonographer. The indications for bedside physician-performed ultrasound for cardiac are hypotension, dyspnea, cardiac arrest, chest pain, and lower extremity edema. For acquisition, ideally the patient will be as supine as they can tolerate. However, if they have difficult windows or are unable to lay flat, occasionally this exam can be enhanced by placing the patient in the left lateral decubitus position, bringing the heart closer to the chest wall. Phased array and curvilinear are optional probes for this exam. However, the curvilinear has a much more challenging footprint that makes it difficult to get between the rib spaces and acquire good views. First, we will start with the subxiphoid view. Placing the probe in the subxiphoid region, we will push down towards the patient's spine and up towards their head, and then flatten the probe against the abdominal wall with the leading edge towards the patient's right. In doing this, we will slide under the xiphoid process using the liver as a window and view the heart from the right apical angle. As mentioned, the leading edge on this will be towards the patient's right. From here on out, we will be discussing orientation as it refers to physician-performed bedside ultrasound, again different from the comprehensive echo ordered by cardiology. The leading edge will be towards the patient's right and on the left side of the screen, versus cardiology's view, which will be towards the patient's left with the leading edge on the right side of the screen. Regardless, the images should look the same. The right ventricle should be adjacent to the liver with the right atria, tricuspid valve, septum, left ventricle, mitral valve, and left atria in view. The head is towards the far field of this image. Next, we will go up on the thoracic wall to obtain our long axis views. At approximately the 4th or 5th rib space, we will place the leading edge towards the patient's left hip and fan, interrogating the long axis of the heart. For the long axis, ideally the septum should be straight across, with the right ventricle in the near field and the left ventricle in the far field. The left ventricle should be slightly horseshoe-shaped, and the apex should be towards the left hip or the leading edge of the probe. This view is essentially opening up the heart like a hot dog bun. For this view, we will review anatomy. I think it is helpful to view the right ventricle as an anterior ventricle, as it does wrap around in the near field in all of the views. So in this view, the right ventricle will be closest to the chest wall, with the left ventricle just behind it, separated by the septum. We can see the left atria coming into the left ventricle in the far field through the mitral valve, with the meaty papillary muscles here and the thin chorda tendineae attaching them to the mitral valve. We can then see the aortic outflow tract with the aortic valve in the middle of the view. The sternum will be on the receding edge, and the apex in the left hip on the leading edge. We will then rotate the probe 90 degrees to obtain the short axis view. In this view, the left ventricle will now be a nice circle. We will fan, interrogating from the aortic valve all the way down to the apex of the heart. Again, the right ventricle will be crescentric in the near field and the left ventricle in the far field. Let's review the various levels here. First is the aortic valve. We can see the tricuspid aortic valve in the middle of the screen with the crescentric right ventricle in the near field and the left atria in the far field. In this view, we cannot see the left ventricle because we are sitting atop it. Occasionally, we are able to view the right ventricular outflow tract and the tricuspid valve in this view. The right atria will be on the leading edge and the tricuspid valve there. As we fan down, the mitral valve will come into view. The mitral valve appears like a fish mouth. Again, the right ventricle crescentric and in the near field, with the right atria and tricuspid valve leading into it. Fanning down further, we will come across the papillary muscles. The left ventricle is still a nice circle. The papillary muscles look like little nubbins in the middle of the left ventricle, and the crescentric right ventricle thinning in the near field as we get closer to the apex. The final view we will discuss of the heart is the apical forechamber. I like to view this as a lateral subxiphoid. With our hand in the same probe position, we slide from the xiphoid process about 3 to 4 finger breadths lateral to the PMI and push up and over the rib, flattening against the abdominal wall or thoracic wall, just as we do with the subxiphoid view. Here, the leading edge will be towards the patient's right, and the right ventricle will be on the side of the leading edge. We are looking at the heart in this view from the feet up. So the apex will be in the near field and the atria in the far field. The right ventricle will be much more sail-shaped and the left ventricle more horseshoe-shaped. For this view to be optimized, ideally the septum should be straight up and down with both the mitral valve and tricuspid valve in view, as well as the right atria, right ventricle, and left atria, all 4 chambers in view. Let's review the anatomy. The apex, or feet, will be in the near field, with the head in the far field. The right ventricle will be on the leading edge and sail-shaped, the left ventricle on the receding edge and horseshoe-shaped. We see the mitral valve, the tricuspid valve, the right atria and left atria. The descending thoracic aorta sneaks behind the left atria in this view, as it descends behind the heart. If you can imagine, as we would fan anterior, we could see the aortic outflow tract coming up and over the heart and then into the descending thoracic aorta. The final view we will obtain is the IVC view. The IVC is a critical portion of the cardiac exam, as it gets us information about preload of the heart. To begin, the leading edge will be placed in the subxiphoid region towards the patient's head, and the provider will keep the probe perpendicular to the body and sweep lateral. The aorta will come out of view and the IVC will come into view as it traverses the liver. The IVC can be noted as it has thinner walls, traverses through the liver, has the hepatic vein sumping into it, and continues through the diaphragm into the right atria. In summary, cardiac exams can help assess a patient's hemodynamic status and guide our management and treatment. However, it's important to begin with the first steps and have a good foundation knowing the anatomy and orientation. As discussed multiple times in this lecture, cardiology and bedside ultrasounds have similar anatomic alignment, however the views are rotated 180 degrees on both the screen and the probe. Thus, the images will look the same. Please be sure when you are practicing that you know your scope, and when indicated, make sure to order a comprehensive echo to fully interrogate the heart and get all the information you need to treat your patient.